Thank you for this very kind introduction, and thank you for inviting me. So I will talk about mapping of persistent AF using the arrhythmia system. We got in Monaco the arrhythmia system 4 years ago, and until 2015, we were using the Panoramic catheter with annotation of what we called the visual fragmentation sites. I think this is something which is very familiar to many of you, and we ended up with maps which were covered by small dots of fragmented sites, and then we were, after the PVI, ablating those, finishing the cases with this aspect of strawberry-like left atrium. But I have to acknowledge that for a number of years, results were very correct. Then we changed our strategy since we acquired the arrhythmia system, and we are performing now a workflow which is starting with PVI. We are still very committed to PVI, and then as a second step, we are trying to perform a driver-based ablation, an extra PV driver-based ablation for persistent AF patients. And I am going to show you how. We are, of course, still very committed to PVI because we have, on top of that classical data coming from the Bordeaux group, recent data on a huge number of patients showing that PV triggers are still largely predominant in all forms of atrial fibrillation. So this still stays the cornerstone of AF ablation, of all forms of AF ablation. But once you have performed and obtained the pulmonary vein isolation, you have to look for drivers. And looking for extra PV drivers, it's something which seems to be a little bit difficult in clinical practice. We have very beautiful experimental proof coming from the group of Jose Jalife, showing that rotors exist. They tend to be pretty stable in persistent AF, but there is a gap between those very beautiful experimental and simulation proofs and clinical practice. And when they tried to translate this concept into clinical practice by means of dominant frequency mapping, results were pretty nice in very selected patients, like in the example that you see up there, but in a randomized, controlled fashion, there was no incremental value to this kind of mapping and ablation when compared to PVI alone. When you try to map AFib in persistent AFib patients, of course, the most intuitive way to do it is panoramic endocardial mapping. And you are all aware of the Topera technology, which is a pseudo-panoramic technology, a contact one, but a low-resolution one, showing rotational sites, but also focal activation patterns. The initial results brought a lot of enthusiasm in the EP world, but nevertheless, subsequent randomized controlled studies were a little bit disappointing. Some other studies are still going on, so the story is probably not finished yet. A more recent system is the Acutus system, which is still panoramic but a non-contact endocardial mapping. The experience is very limited, but we have seen in the literature some very nice example of localized rotational activation sites. Bioscience Webster invested also in a software module called CartoFinder, which had several different versions. The first one was based on the big basket, was a pseudo-panoramic low-resolution mapping, which was very quickly abandoned. Then they brought a new mapping, a sequential mapping-based module with the Pantarray, with phase mapping, also abandoned. And now they are using the sequential technique and unipolar mapping in order to show potential drivers for atrial fibrillation. I'm not mentioning CardioInsight because we are not seeing any news about it anymore in the domain of persistent atrial fibrillation. So we have in the literature, nevertheless, some proof that sequential mapping is also a valuable tool in localizing extra PV drivers. And you have some data from the Bordeaux group showing clusters of radial activation sequences. You know, you are certainly familiar with the papers from the Marseille group showing sites with spatio-temporal dispersion, which are successfully ablated in order to terminate AF. And we also have some data from the Taiwan group showing with a nevertheless very low resolution sequential mapping, a point-by-point mapping, showing some rotor sites. And ablation of those sites seems to be pretty successful. So we hypothesized that if rotors exist, and if they are stable in space and in time, or predominantly stable, or even more, recurrently appearing in a certain site, we should be able to visualize them with a sequential mapping technique, provided that you have a lot of points, but also a system which is able to perform some statistics on that huge number of points. And here is a nice example. You see a left atrium image, AP and PA views, showing gray areas, large gray areas. And those areas are not gray because they are scarred and low voltage. Look at the local potentials. We are way above the scarred threshold. Nevertheless, the system did not find any concordance between neighboring points in what concerns the local activation time. So the system did not put any color on the map. It left all those areas gray because they correspond to fibrillatory conduction. That is not interesting. Nevertheless, on the lateral aspect of this left atrium, there was a focal propagation pattern coming from a site which showed very pathological continuous fragmentation. And ablation on that site terminated AF in this particular patient. So starting with that case, we designed an approach where after performing the wide circumferential pulmonary vein isolation, we remap the left atrium with the arrhythmia system by taking time reference at the level of the left atrial appendage. We are selecting on that cycle length curve, which shows AF, irregular cycle length, the predominant one, and we are, after that mapping, defragmenting, limiting our ablation only to rotating activation sites and to foci with centrifugal activation. What can we see on these maps? We can see several types of coloring, of coding, color coding of the map. We see gray areas, which can correspond, of course, to scars. We can see gray areas, as I showed you before, corresponding to this lack of statistical coherence between neighboring points. But we can also see regions with uniform color, which correspond to a very nice wavefront, organized wavefront of activation, like in an atrial tachycardia. But we can also see some sites, which might be very interesting, which are rotating activation sites. And we just saw a very beautiful example before in the PVs. Now, this is an extra PV one. And you can appreciate that in the center of that rotation, you have a continuously activated site, and all around it, propagation is repetitively recurring with the same pattern of activation. Now, let me show you an example of a procedure. Now, this is a case of with a long-standing persistent atrial fibrillation in a 69-year-old woman. We start with PVI. You see how large and antral the ablation is. And you see that just by performing this, we slow down the cycle length at the level of the left atrial appendage, but we also organize the AFib on the surface ECG. So a tremendous amount of work is already done just with the PVI. And then we remap. And this is what we obtain just after PVI in this particular case. And I would like to focus your attention, because I don't have a pointer, on the AP view at the upper base of the left atrial appendage. And I hope you can all recognize a rotating activation site there. And if you just move a little bit your attention, still in the upper part of the AP view towards the right aspect, you can see a focal activation pattern. Now, of course, these are colors, and you don't have to trust only the colors. You also have to check the electrograms, and you have to be sure that this corresponds to what you would be expecting in case of a reentry, of a localized reentry. with a continuous fragmented potential in the center of it in these cases, to what, of course, a very organized propagation pattern in case of focal propagation sites. And of course, you need to be sure that there is no extrapolation from the system, and you have to neglect all those sites where color is overestimating the local propagation pattern. Now, we are ablating these specific sites, a limited amount of ablation in each case, and in this particular case, we avoid to ablate some fragmented sites which correspond to collisions. And they are highlighted in this image by the black dots, by the black tags. And you see that these sites, although highly fragmented, they correspond to the collision of the wavefronts coming from the rotating side and from the focal activation pattern site that are located in the superior aspect of the anterior wall. After 750 seconds of radio frequency, we stopped IF in this particular patient, and we find that this example of low-standing persistent IF is pretty encouraging. Now, we started this approach late in 2015. We stopped the inclusion in August of this year. We performed 90 cases with this approach, and 51 of them were all de novo procedures in persistent IF patients coming to the lab in AFib. So I'm not going to show you results on induced AFib in the lab. Those patients were in AFib for 9 months at minimum. That was the duration of the current episode. They arrived to the lab with. Of course, these persistent patients have hugely dilated left atria. The amount of low voltage is pretty impressive. You see that 64% of the left atrial surface is below 0.5 millivolts. And we have recent data showing that voltage mapping in AFib is better correlated with scar on MRI than voltage mapping in sinus rhythm. And look what we can see with this, let's say, different stepwise approach. You can see in the upper part the initial maps that were performed in this case. 20% of the surface of the left atrium had an uniform propagation pattern. Once we performed the CPVI, that amount increased to 30%. And so the left atrial appendage was concerned, but the organized pattern of activation extended to the lateral aspect of the left atrium. And once we performed the first pass of driver ablation, almost the entire left atrium was organized, but the patient was still in AFib, and you can appreciate it on the surface ECG and on the CS recordings. Statistics work in the same sense. You see that organized regions increase from 60% of the surface to 23% by the CPVI only, and to 28% of the surface after the first pass driver ablation. We are organizing the AFs also by showing the further diminishing of the number of drivers with remapping. After the CPVI, we localize in mean 7 drivers, most of them rotational, just 1 focal. And after the driver ablation, that number comes down to 5. Some of them are the same. We have to ablate a little bit more in those same areas, but still with the predominance of the rotational activation sites. Now, these drivers, I told you that we are targeting 2 types of propagation pattern, rotational and focal. And in order to prove you that we are not getting fooled by colors, I'm going to show you what differentiate these 2 patterns of activation. First of all, the rotational one, you can appreciate how repetitive the pattern of activation is in that particular site. You can also appreciate how highly fragmented and almost continuous the bipolar potential is in the center. And this is completely different from the focal activation pattern site. The differences between the 2 are hugely significant. The coverage of the cycle, of the local cycle length, is 82% for rotational drivers versus only 49% for focal drivers. The bipolar local electrogram amplitude is much lower for rotational drivers, and this corresponds, in theory, to what a mathematical model of a rotor is. When we look closely to the focal drivers, actually we realize that in a majority of them, the earliest activation site has an RS pattern, and not a QS pattern. And that R wave has a significant amplitude, which translates most probably some other type of activation happening elsewhere, like in the epicardium. And this focal activation site is most probably, in many cases, just the epi to endo breakthrough sites. Where are these drivers located? So once again, this is only the post-CPVI maps in the de novo patients. And what you can appreciate is there is no rule. They are located almost everywhere, but with a predominance, nevertheless, for the anterior wall and for the lower part of the posterior wall. I'm not pointing out to those regions. I'm just pointing out that some of the current, let's say, approaches by systematically performing the box isolation on the left or the left atrial appendage isolation are highly questioned by this kind of distribution. How about the results? In mean, we are performing 740 seconds of extra pulmonary vein radiofrequency in order to stop AF. And we have an overall acute termination of AF of 67%. If we respect the entire protocol, that means 2 remaps for the left atrium and 1 final map for the right atrium if AF is still ongoing. We can increase this percentage, and we consider this result as pretty encouraging. We are now closing the follow-up for these patients, and up to now, the results are very, very encouraging. If some of you are still concerned about the reproducibility of the technique, what I want to tell you is that since 1.5 years now, we are working with the Research and Development Department in Boston Scientific in order to develop an algorithmic detection of these sites to be targeted with the ablation. Just imagine that you might have, in a few months from now, I hope, a software module that in the LumiPoint fashion would highlight those sites for you. And you see here a very nice example where only one site, where we even had bump termination of AF, was highlighted by the module. Of course, this is a very complex algorithm. Many of the top state-of-the-art criteria are being integrated into it, but unfortunately, I'm not allowed to go into the detail of it at this moment of time. And if some of you are still not convinced that extra PV drivers exist, look at this result. The research and development section in Boston Scientific performed an analysis of more than 80 of those maps. And in a significant number of patients, they saw clustering of the cycle length. Just imagine that you have a tool that on those dozens of thousands of points will classify them just based on the local cycle length of each point. And in some cases, still a minority, but very important, only clusters of cycle length exists. This means, like in those 2 examples that are displayed, that those AFs are explained by 2 concomitantly ongoing ATECs. Imagine that you can select the first one, you get rid of it, and the second one, you get rid of it, and you get rid of the AF. I would like to spend the last minute and a half just to develop in 5 arguments the rationale for persistent AF mapping and ablation with the arrhythmia system. First of all, and this always had been emphasized by Professor Meyer, HD mapping allows improved diagnosis of abnormal electrograms. And we have this work from Ella Danter, who compared point-by-point mapping with the ablation catheter versus the Panoramic catheter. And he clearly showed that the smaller size electrodes are the main factor responsible for the differential resolution between these catheters. Now, the Panoramic catheter has 1 millimeter ring electrodes. Imagine you bring that down to 0.4 square millimeter, like is the case for the Orion. Now, with the Orion, you also improve the signal-to-noise ratio. And we demonstrated that the noise on the Orion catheter is the lowest possible. We measured it between 10 and 12 microvolts systematically in all the cases. This, of course, increases the signal-to-noise ratio, and you get better diagnosis in complex patients. The second one, and I don't have to insist on that, it has been largely commented before, the Orion is a better tool to assess PV disconnection than the LASSO, which is overestimating this disconnection. The third reason, and I hoped I convinced you, is that with this mapping system, you might localize extra PV drivers. And hopefully very soon you will have an automatic tool for highlighting them. Then when you stop AF and the patient goes into ATEC, you have in your hands the best tool to diagnose and to treat efficiently that ATEC. And finally, in France at least, there is let's say a polarizing of the EP world between these two strategies. One which is, let's say, electrogram based only, but extended, and one which is line based only. Of course, both of those authors have their arguments, but this could be a consensus strategy, just taking the best out of those two. Thank you very much for your attention.